Good morning everyone. Today I will take lecture on endo and perio lesions. These are the content of the lecture. I will start with the definition given by the Stock: an isolated, usually narrow, deep probing depth of the pulpal or periodontal origin. Lesion with submarginal or intrabony periradicular bone loss of pulpal and or periodontal origin that communicates with the oral cavity via probing defect. A localized periodontal probing depth of the pulpal or periodontal origin. Coming to the classification given by the Cohen, that may include first one is the primary endodontic lesion, primary endodontic lesion with secondary periodontal involvement, primary periodontal lesion, primary periodontal lesion with secondary endodontic involvement. Other one is the true combined lesion, concomitant pulpal and periodontal lesion. Classification given by Wien: in type 1, tooth in which symptoms clinically and radiographically simulate periodontal disease but are due to the pulpal inflammation. In type 2, tooth that has both pulpal and periodontal disease concomitantly. In type 3, tooth has no pulpal problem but require endodontic therapy plus root amputation to gain periodontal healing. In type 4, tooth that clinically and radiographically simulate pulpal or perioapical disease but in fact have periodontal disease. Classification given by Grossman: it's like the lesion requiring endodontic treatment only, lesion requiring periodontal treatment only, and that will require the both. So in group 1, necrotic pulp and apical granulomatous tissue replacing the periodontium with or without sinus tract. Chronic periapical abscess with sinus tract, longitudinal and horizontal root fractures, pathologic and iatrogenic root perforations, teeth with incomplete apical root development, endodontic implants, replants and transplants, teeth that require hemisection, root subversions, then lesion requiring periodontal treatment only, that is comes under group 2. In that, occlusal trauma causing reversible pulpitis, occlusal trauma plus gingival inflammation resulting in pocket formation and reversible pulpitis. Suprabony or infrabony pocket formation treated with overzealous root planing and curettage leading to pulpal sensitivity. Extensive infrabony pocket formation extending beyond the root apex and sometimes coupled with lateral or apical resorption, yet with pulpal that responds with in normal limits to clinical testing. Lesion requiring combined endo and perio treatment, that is comes under group 3. In that, any lesion in group 1 that results in irreversible reaction in the attachment apparatus and requires periodontal treatment. Any lesion in group 2 that result in irreversible reaction to pulp tissue and also requires endodontic treatment. Now coming to the etiological factors, then atypical anatomic factors may include malaligned tooth, multi-rooted teeth, or tooth having additional root, additional canal, cervical enamel projection, large lateral and accessory canals. Traumatic factors like with gingival inflammation, tooth fracture, pulp or periodontal involvement with sinus tract, cellular changes like internal resorption or external resorption. Miscellaneous factors are iatrogenic and systematic. If sinus tract is there, then it will be infection will be from the canal and narrow, and if infection is there from infrabony pocket, then it will be from gingival crevice and it will be wide than the sinus tract. Causes given by the stock, that may be due to the root canal infection. It can be due to the root fractures like crown fracture, root fracture in vital and non-vital tooth. Root perforations. Here in RVG, we can see the canal is obturated in the furcation area, that will cause the irritation, chronic irritation, and leads to the periodontal infection. Root resorptions, that may be internal or can be external. Anatomical anomalies of the tooth, for example, palatogingival groove, enamel pearls, root division, fused teeth, and invagination. Orthodontic treatment. In some orthodontic treatment, pocket formation will be created due to the orthodontic tooth movement, that will leads to the plaque accumulation and food accumulation over there, and that will leads to the periodontal infection. Poorly designed restorations like overhanging restorations in periodontal area may cause the irritation to the periodontium, and that will leads to the periodontic lesions. Localized periodontal disease like transplantation and replantations. Multiple Endo-Perio lesions, isolated lesions upon generalized periodontitis. In OPG, we can see the generalized periodontitis in there. Chronic periodontitis, aggressive periodontitis. Controversial aspects concerning the combined lesion. Pulpal lesion can be a periodontal lesion also, but periodontal lesions can be a pulpal lesions that is still questionable. According to Schecker, Messler, Sarnecki, and Schilder, venous blood flow will be the outward in such lesions. The drawback will be the lateral and accessory canals, in that the flow will be in the both ways. The pathways of the infection, then it can be a physiologic pathway or iatrogenic pathway. In physiologic pathway, apical foramen, lateral canals, dentinal tubules, periodontal ligament, alveolar bone, neural pathways, vasculolymphatic pathway, palatogingival grooves, and cementum defect. And if pathways are iatrogenic, then it can be due to vertical root fractures and perforations. Here in figure, we can see the various regions from where the periodontal or any pulpal infection may spread. If sinus tract opening will be there on marginal gingiva, then it will be a primary periodontal lesion. But if sinus tract opening will be at the apical area of the tooth, and clinically it will be seen at the vestibular area of the tooth, then it will be a primary endodontic lesion and secondary periodontal lesion. Here we can see the sinus tract opening over the lateral border of the tooth surface. Here is the histopathologic diagram of the periapical lesion. If we talk about the comparison between the marginal periodontitis and apical periodontitis, then marginal periodontitis will be present at the cervical level, and apical periodontitis will be present at the apex level. Plaque accumulation will be there in marginal periodontitis, and pulpal inflammation will be present in apical periodontitis. In marginal periodontitis, horizontal or vertical bone loss will be seen, and it can be generalized. But in apical periodontitis, seldom bone loss will be seen, and it will be localized and deep. In marginal periodontitis, the lesion will be open, and in apical periodontitis, it will be contained. In marginal periodontitis, attachment loss associated with anatomic defect on root, nature of pathogenic flora, necrotic and infected pulp, host defense mechanism defect will be there. But in apical periodontitis, aggressiveness associated with lateral and apical foramen, nature of the flora, and apical host defense. In marginal periodontitis, periodontal probing and radiographic examination is required, but uh, apical periodontitis can be encountered with the radiographic examination only. Now coming to the differential diagnosis, then if pulpal disease is coming to the differential diagnosis for the either it is pulpal disease or periodontal. So if pulpal infection will be there, then it will be the pulpal disease, and if periodontal infection is there, then it can be says that it is a periodontal infection. If talk about the vitality of the tooth will be non-vital in pulpal disease, and tooth will be vital in periodontal disease. If restorative procedure have been carried out priorly, then deep and extensive lesion may be the cause of the pulpal disease, and in periodontal disease, restorative procedures are not related anywhere. Plaque and calculus are related and primary cause of the periodontal disease, but it's not related to the pulpal disease. Inflammation will be acute in pulpal disease and chronic in periodontal disease. Pocket formation will be there in single tooth, and it will be narrow in pulpal disease, and multiple tooth involvement and wide lesion will be there in periodontal disease. pH value is acidic in pulpal disease and alkaline in periodontal disease. Microbial infection and microbial presence will be few in pulpal disease and complex in the periodontal disease. If we talk about the radiographic features, then a pattern of bone loss will be localized and wide in pulpal disease and generalized and wide in periodontal disease. Periapical radiolucency will be seen in pulpal disease, and it will be no periapical radiolucency will be seen in periodontal disease. Vertical bone loss will be present in periodontal disease, but no vertical bone loss will be present in pulpal disease. Coming to the histopathological examination, then junctional epithelial granulation tissue will be present minimal and apically in the pulpal disease, but it will be present in the coronal portion of the tooth in the periodontal disease. Mainly it will be seen in the gingival margins and gingival sulcus. The gingiva will be normal in pulpal disease, and recession and pocket formation will be seen in periodontal disease. Coming to the treatment part, then root canal treatment is required in pulpal disease, and periodontal therapy is required in periodontal disease. Sometime that combined therapy will be required in some disease. That primary we have to go for the root canal treatment, and secondarily periodontal therapy, or in some disease primary periodontal therapy will required, and secondarily root canal therapy will be done. Here are the problems which can be encountered during the diagnosis. Coming to the vertical root fracture, it will be very varied radiographic picture, and different angulations are required. Rest of all not important. Developmental grooves can be cause a problem in the diagnosis. Biopsy and histological analysis will be done in such cases. Effect of pulp and its treatment on periodontium. In periodontal inflammation and bone loss, submarginal bone loss, horizontal bone loss, vertically intrabony pockets, and furcation involvement will be seen. In periodontal wound healing, the traumatized and necrotic pulp will be seen. Root canal infection, that will cause the compromised healing, gingival tissue thickness, and alveolar bone level will be lesser than the normal tooth, and some iatrogenic problems will be there. Effect of periodontal disease and its treatment on pulp. So in periodontal disease and pulp, it will be limited, channel will be closed, and dystrophic calcification can occur. Sufficient virulence factors are present in pulpal disease, and tooth will give the poor prognosis. The treatment option will be extraction or the root resection. In periodontal treatment and pulp, scaling and root planning is required. Excessive cementum remnants and compromised pulp will be seen. In primary endodontic lesion, the caries, trauma, and restorative procedure will affect the pulp that will cause the inflammation of the pulp. The inflammation will be apical, lateral, or fulcral infection is there that will cause the pain, swelling, tenderness, marginal gingival swelling, and suppurative process, and sinus tract formation will occur. If sinus tract formation will occur in multirooted teeth, that general group 3 through and through furcation defect will occur. If PDL and patent channels will be there, then infection will be occur in the gingival sulcus. The diagnosis will be the necrotic pulp, and vitality test will be the negative in such cases. The treatment option will be the root canal treatment. In primary endodontic lesion with secondary periodontal infection, so unchecked endo lesion that will lead to the periapical alveolar bone destruction in interradicular area that will affect hard as well as soft tissues. Drainage will be required. Plaque and calculus accumulation will lead to the apical attachment migration in or periodontal disease. Diagnosis will be necrosis, and calculus accumulation will be there. Treatment in such cases, endodontic plus periodontic treatment will be required. For the primary periodontal lesion, lesion will be occur in the gingival sulcus that will cause due to the plaque and calculus accumulation that will cause the gingival inflammation. If infection goes to the apex, then it will affect the alveolar bone as well as PDL. That will cause the clinical attachment loss, and acute abscess will be formed. In lateral root furcation and trauma form occlusion is there, then osseous defect will be occur. Diagnosis, tooth mobility, positive pulp mobility can be seen. Pulp test will be positive. Broad based pocket and plaque and calculus accumulation will be seen. Generalize. For such cases, only periodontal therapy will require, like root planning and flap surgeries. Primary periodontal and secondary endodontic lesion, periodontium and pulp both are involved, and that will leads to the deep pocket or extensive periodontal disease, maybe due to the past treatment. Maybe either it is periodontal treatment or endodontic treatment. The treatment will require both endo and perio treatment. For example, through combined lesion and concomitant lesions. How to diagnose the endo-perio lesion? So we have to take the history. We have to check the history of dental and pulpal pain. We have to take the history of periodontal symptoms like bleeding, reoccur of infection, and mobility of the tooth. Then we have to check the nature and duration of the infection and the related risk factors. Sign and symptoms of the pulpal and periapical disease and pulp vitality test will be carried out. Periodontal charting will be done by doing the probing profile, and we have to check the recession, mobility, furcation involvement, and attachment loss clinically. Clinical signs of pocket formation. So we all know that the stripling will be absent in any gingival inflammation. Then bluish red marginal gingiva can be seen, or vertical zone extending from the marginal to attached gingiva. Rolled edge separating gingival margin from tooth surface. Enlarged edematous gingiva will be seen. Bleeding and suppuration, loose extruded teeth can be seen. Bleeding on probing will be present in such cases. Symptoms of pocket formation. It will be usually painless, or the localized or radiating pain sensation or sensation will be present, and after eating it will gradually diminishes. Fall taste in localized areas, sensitivity to the hot and cold. Toothache in absence of caries are present. In such cases, we have to measure the biological depth, probing depth, at which force the bleeding on probing will occur. The normal force will be the 0.75 Newton. The pocket depth we have to record, level of attachment and gingival recession is present or not. We have to check for that. 6-point charting will be done. The probing will be done in distopalatal areas, midpalatal areas, mesiopalatal areas, and continuous probing profile will be checked. We have to do the probing surrounding the tooth and check for the pocket depth of the pocket. Here we can see the score of the both side, buccal, distal, lingual, and mesial, and we have to give the scoring according to the probing profile. If long and narrow pockets is there, then lesion will be the endodontic origin. Lateral endodontic abscess. In lateral endodontic abscess, wide and deep pocket can be seen, and blowout of the lesion can be seen clinically. Here in this picture, we can see the blowout lesion while the probing, or when we penetrate the probe in the lesion, the pus discharge can be seen. Now coming to the radiographic features, then radiographic pattern of the bone loss will be apical extent of the bone loss, definite PDL space will be absent, shape of the bone defect will be angular or marginal bone loss will be there. Bone defect contributed by pulp infection. Periodontal infrabony defect, it will be 2/3 of the root length. Horizontal bone loss, it will be 2/3 of the root length, and periodontal bone loss involving root end. Here we can see the bone loss surrounding the tooth, and tooth is only connected to at the apex level with the bone. Acute pain is generally absent in Endo-Perio lesion. If Endo-Perio lesion is there, then tooth will be usually isolated, narrow, and localized pocket can be seen. Causes will be the endodontic infection, perio infection due to the fracture, any type of resorption, and due to the anatomy of the tooth. We have to check the endodontic status of the tooth. If tooth is root canal treated, either it is root canal treated or not. If root canal treated, tooth will be there. Then we have to evaluate the adequacy of the treatment. That cavity preparation is under prepared or over prepared. Any perforation is there or not. Any zipping or ledge is there or not. If tooth is obturated, then we have to check radiographically that either it is underfilled, overfilled, or poor adaptation of the gutta percha is there or not. And we have to evaluate for the retreatment is possible or not. If root canal therapy is not done, then we have to carried out the vitality test of the tooth. If retreatment procedures are feasible, then we have to go for the oral health instruction. Then we have to put the patient on the follow-ups and check for the resolution of the tooth. If no tooth give the negative resolution and negative results, then do the first stage endo treatment. Cleaning and shaping of the canal will be done, and calcium hydroxide or Metapex dressing is given to the patient for the 1 week or the 15 days. Then again we will check for the resolution, and it again negative resolution will be there. Then treatment option will only to extraction of the tooth. If retreatment is not feasible, then oral health instruction plus debridement will be done, and follow will be done after 15 to 20 days. If tooth will give no response, then extraction will be done. For the vitality test will be done, and tooth is vital, then perio treatment will be done, and will check the resolution. If negative resolution is there, then we'll check vitality again, and if any doubt, we'll do the endodontic therapy, that is root canal treatment, and still it will no resolution, then we'll find the other causes of the infection, and at the last the treatment option will be extraction, resection of the roots, or hemisection of the root. If vitality test is negative, then root canal treatment will be carried out. Here are the some treatment alternatives. We can do the root resection as well as regenerative techniques can be done. In root resection, the definition is sectioning and removal of one or two roots of the multi-rooted teeth with accompanying odontoplasty. Root amputation, the removal of one or more roots of multi-rooted tooth while the others are retained. In root amputation, selective amputation can also be done. In that, we have to remove only infected portion of the root, and rest of will be survived. In such cases, if selective amputation is done, then we have to place the MTA at the root end, and then obturation will be done. We can do the hemisection. Hemisection is the removal or separation of root with its accompanying crown portion of the mandibular molars. Radisection. Radisection is the newer terminology for the removal of the roots in maxillary molars. Here noted that hemisection is not done in maxillary molars due to the presence of palatal root. Bisection or bicuspidization can also be done. Bicuspidization is a separation of mesial and distal roots of the mandibular molar along with its crown portion, where both segments are then retained individually. The difference between bicuspidization and hemisection is, in hemisection we have to remove either mesial or distal, which one is infected. The whole portion of mesial or distal will be removed. But in bicuspidization, we'll separate the tooth and will retain the both segments of the tooth. In root resection is done in the cases where furcation involvement is there. Here is the classification for the furcation involvement. In class 1, horizontal loss of periodontal support will be lesser than 1/3 of the tooth width. In class 2, horizontal loss of periodontal support will be greater than 1/3 but not encompassing the total width of tooth. In class 3, horizontal through and through destruction of the periodontal tissue in the fulcral area. Indications for the resection. The first one is the periodontal indications. In that, several vertical bone loss involving only one root of the multi-rooted tooth. Through and through furcation destruction is there. Then we'll do the root resection. Unfavorable proximity of the roots of the adjacent teeth. Several root exposure due to the dehiscence. Next one is the restorative and endodontic indications. In that, if prosthetic failure of abutments within a splint is there, then endodontic therapy will be done. In endodontic failure due to the perforations, overextensions, obstructed canal, separated instruments, root resorption, then restorative and endodontic therapy or resection will be done. Vertical fracture of one root, restorative reasons, for example, subgingival caries, erosion of the large part of the crown and root, traumatic injury, and combination of any of these. The contraindication for the root resection is fusion root. That will be impossible in such case to separate the root. If root are angulated or cow canals are present, then in such cases root resection will be difficult or impossible due to the presence of mandibular canal or inferior areolar nerve just below that. If root morphology is not feasible for the root resection, then it is also the contraindication of the root resection. Improperly shaped occlusal contact are also contraindication. Surgical consideration, we can do the buccal or palatal flaps. We can go for the relieving incision, intraclavicular incision, full thickness flap, under surface of crown and beveled. These are not important at UG level. For the regenerative techniques, guided tissue regeneration will be carried out. In differential tissue differential tissue development will be done. For the GTR, we have to use the barrier that can be either resorbable or non-resorbable. For the resorbable barriers, it can be of collagen barrier or synthetic barrier. In GTR, enamel matrix derived protein is also used for the regeneration. First off, in any endo-perio lesion, we have to start the antibiotics to the patients. For that, we can prescribe the tetracycline 250 mg with quid approach. We can prescribe the doxycycline 100 mg BD or OD, metronidazole 250 mg TID for the 7 days, and we have to prescribe the chlorhexidine mouthwash to the patient thrice a day. These are the reference of the chapter. Thank you.